alaikum. So my talk will be street drugs in Saudi Arabia. So when we deal with patients in the emergency department who are intoxicated with illicit drugs, most of the time it's challenging because most of the time we don't know what they took. Okay, you can elicit in the history if they took pills, tablets, they sniffed a powder, for example, or smoked a weed-like substance. So in this talk, I will go over what weed-like substances in Saudi Arabia could mean and how would you manage it. If it's tablets, what's the most common culprit? And if it's powder, what could it be? It will be heavily based on an analysis done by Dr. Maha Al-Mazroua, head of Poison Center in the Eastern Province. They basically analyzed seized tablets, and hashish samples, and powder, and investigated what they could be. So I'll begin with first with the most common street drug by far in Saudi Arabia, which is called hashish. So hashish, as you know, is the slang term for cannabinoids. Cannabinoids are basically chemicals extracted from the plant cannabis sativa. There are 60 molecules in it. The most active one is called THC, Tetrahydrocannabinol. If the leaves and flowers are smoked, they're called marijuana. The pressed resin of it is called hashish, and it usually contains more concentration of THC. So what do THC do? Well, it actually acts on receptors that we have in our brain called CB1 and CB2 receptors. When they're activated, they cause a sensation of euphoria, calmness, heightened sensation, and some physiologic effects as well, like slight tachycardia and slight hypotension. So the analysis, when it was done, they investigated the seized hashish tablets, hashish samples, and they found that they actually contained cannabinoids, okay, including THC. Some of them were adulterated with heavy metals, but the active ingredients was THC. Now, are cannabinoids dangerous? So, in fact, you know, the acute toxicity of cannabinoids is actually benign. So if it's benign, how would they present to the emergency department? So usually they will not present to you in the ED. When someone like smokes, for example, a weed or something, they don't usually present to you. They can present, though, within 4 different situations. First, they can present to you with paranoid psychosis, okay? So in susceptible individuals, if they get exposed to cannabis or weed, they can have paranoid delusions, and they can be agitated because of paranoid delusions, okay? Now, they could be severely agitated that they require benzodiazepines in the emergency department to sedate them, and then when asymptomatic, you can discharge them. The second scenario is a worried parent brings his kid because he accidentally ingested a part of hashish or something called brownies or cookies, which are cooked with weed. So is it safe to discharge them? Well, in fact, in kids, there has been numerous case reports showing that it can cause abrupt coma and abrupt obtundation if they're ingested. So it's potentially life-threatening. So in children, you need to observe them at least for 4 hours before discharging them. And if they're symptomatic, then you can discharge them. If they're symptomatic, you have to admit them and treat them supportively. The third scenario which they can present to you is actually with a syndrome called cannabis hyperemesis syndrome. Now, this syndrome is characterized by recurrent cyclical abdominal pain, vomiting, and nausea in patients or people who use cannabis or marijuana for prolonged periods of time. And it's characterized that it's really resistant to antiemetics like ondansetron and metoclopramide, and it really responds by taking hot baths and hot showers. For some reason, hot baths and showers activate capsaicin receptors or TRPV receptors, and they suppress the vomiting episode. So if they present to you in the emergency department, what can you do? You can give them antiemetics, IV. If it fails, there are some studies showing that IV haloperidol, or recent studies showing that capsaicin cream, which is a cream that can be bought from the pharmacy, that actually it's basically it's burning, So it activates the capsaicin receptors and the TRPV receptors and suppresses vomiting. There was a case report. The recent study was a retrospective case series done in the emergency department where they claimed that, 13 patients, 10 of them actually had antiemetics for cannabis hyperemesis syndrome. None of them responded to it, and they only responded after application of capsaicin cream on the abdomen, vomiting ceased, and they were discharged. So you can try it if a patient comes to you in the emergency department. The fourth presentation is a patient who says that he smoked a weed-like substance, but he presents to you in a different symptom. He presents to you like a sympathomimetic picture. So he's tachycardic, hypertensive, he has agitated delirium, he is sweating. What could it be? Well, there is a class of chemicals called synthetic cannabinoids that can present exactly like this. Okay? Now, what are synthetic cannabinoids? Synthetic cannabinoids are molecules made by scientists in the 90s or the 80s to study the endogenous cannabinoid system in our body, the endogenous cannabinoid receptor. So they have high affinity, 100 times more affinity than natural cannabinoids. And what happened is that drug dealers took those compounds, packaged them in containers, and they wrote on them not for human consumption. And they sold them in the internet so that it will escape the legal implications. So people know that when they get it, of course they will basically say it's for plant food, you just put it in plants, but people know when they take it, they can smoke it and they get high. Now the problem with this, to the surprise of toxicologists and to the surprise of people who used it, it didn't cause much of a cannabinoid syndrome. But in fact, a lot of the time, it produces a syndrome similar to a sympathomimetic toxicity with the complications of it. It causes seizures, strokes, myocardial infarction, acute renal failure. There's numerous case reports showing this, myocardial infarction, acute renal failure, status epilepticus, and cardiomyopathy. So it is dangerous. It's not like natural cannabis. And when someone smokes this, he might present to you with a sympathomimetic-like picture. Treatment is the same with benzodiazepines and supportive therapy. So, what if it was tablets? What could it represent? So, the tablets, the most common culprit and the most common tablets we have are something called Captagon. Okay? So, what's Captagon? Well, Captagon is a drug used to treat ADHD. Okay? It's amphetamine plus theophylline combined together. And when the drug was banned, it went to the black market. But what's interesting is that not all Captagon is Captagon. In fact, the analysis that was done, and they seized all the tablets, illicit drug tablets, that were thought of to be Captagon, none of them were Captagon. All of them were actually amphetamine and amphetamine derivatives. Not only this, but a lot of them, all of them, were adulterated with caffeine and theophylline. Half of them were adulterated with paracetamol and allopurinol. So, what is amphetamine? So basically, they are drugs that stimulate the secretion of norepinephrine, epinephrine, dopamine, and serotonin in the central nervous system. They produce the usual sympathomimetic toxicity with the usual complications that you all know about, like strokes, myocardial infarction, aortic dissection, rhabdomyolysis. Amphetamine can actually be modified to methylamphetamine, for example. A methyl group is attached there. Methamphetamines are called, they are crystal meth. This is what methamphetamine is. Here they call it a shabo. Has a longer duration of action, more potent. And if it's modified in that way, it will lead to MDMA. Now, MDMA has more serotonergic properties, so cause more psychedelic effects, less sympathomimetic effects. And it's implicated in SIDH and can cause hyponatremia and hyponatremia-associated seizures. MDMA is not very common in Saudi Arabia. So treatment, of course, you all know it's benzodiazepines and supportive therapy. What I want you to remember is that with benzodiazepines, be generous. It is not uncommon that you reach 100 milligram of diazepam and 30 milligram of lorazepam until the patient is sedated. Okay? This will usually take care of the cardiovascular effects as well, like hypertension, tachycardia. But if not, don't use a beta blocker, use phenethylamine as an alpha blocking agent. Supportive care, most important thing to remember is monitor for hyperthermia. If the patient has a temperature, you have to put a rectal probe, monitor core temperature, active cooling to make the temperature below 39 degrees Celsius. Now, this is just a slide because a lot of them are adulterated with caffeine and theophylline. Just keep in mind, if the patient doesn't do well, he might be caffeine or theophylline toxic. Treatment is usually the same, but they deviate a little bit because these methylxanthines can cause prolonged seizure, prolonged hypotension. Hemodialysis is indicated. Sometimes beta blocker is indicated because they actually cause beta-2 agonist effect in the skeletal muscle vasculature and cause vasodilatation. So another tablets that are common and substance of abuse in teenagers and young adults are benzodiazepine derivatives. So Roche, which is clonazepam, and Xanax, which is aprazolam. We all know how to manage benzodiazepine overdose. It's straightforward and easy. But what you need to remember is that they can present with acute benzodiazepine withdrawal. Acute benzodiazepine withdrawal is potentially life-threatening, just like alcohol withdrawal. The difference is that it can present days to weeks after cessation of benzodiazepine because it can accumulate in your blood and gets metabolized slowly. So it can cause death. These are 2 case reports where people who were using therapeutic benzodiazepine, they stopped it, they presented to the emergency department with hyperthermia, they seized, and they died. So, with benzodiazepine acute withdrawal, treatment is exclude life-threatening illness, fluid electrolyte management, and then you have to give them benzodiazepines. Diazepam is the preferred medication. Expect large doses of diazepam or lorazepam in those patients. Okay, 100 milligrams, sometimes even more than 200 milligrams of diazepam in the first hour. Now, recently we had a patient who was in benzodiazepine withdrawal who was resistant to benzodiazepine treatment. Now, what is resistant? In the literature, there's a definition for ETH, benzodiazepine resistant in ETH withdrawal, which is defined as 10 to 20 milligram lorazepam in the first hour or 100 milligram of diazepam in the first hour. So what can you do in those patients? You can actually start any of those medications as a drip. It's been proven to reduce benzodiazepine requirements in alcohol withdrawal patients. Phenobarbital, propofol can, probably you will end up intubating them if you do this. Dexmedetomidine and ketamine are more protective to the airways. So the last thing is, as tablets, is Lyrica. Lyrica is very common, especially among female, to get for it to be abused. And in overdose, usually it causes just drowsiness, but if it's severe overdose, it can cause coma. You also have to remember that it can cause myoclonus and seizures in overdose as well. So when managing those patients, don't give activated charcoal in overdose because they will have either a decreased level of consciousness or seizure. So another examples of tablets or pills is heroin capsules, LSD, tramadol, and morphine. So what about powder? Well, the analysis actually revealed that most of the powder was heroin, 10% was methamphetamine or crystal meth. Powder also can be cocaine, it can be ketamine. Ketamine here is called aqar al-ahsina. It's actually stolen from vets because they use it to sedate horses, and they can actually steal it and abuse it. Okay, so the last thing that could represent powder or salts is something called bath salts. It's not common here, but you might see it. The concept is the same as synthetic cannabinoids, but they are synthetic amphetamines or synthetic cathinones. So they are designed by drug dealers to escape legal implications and sold as bath salts just to put it in your bathtub for aroma or aromatherapy. But people know that if ingest it, inject it, or sniff it, they will actually be high. The toxidrome is exactly like an amphetamine toxidrome. The only difference is that it also can cause SIDH associated hyponatremia and hyponatremic seizures. Okay, so this is my conclusion slide. And I just want you to remember that when you manage an illicit drug overdose in the emergency department, the most important thing is to focus on the symptomatology of the patient and the toxicity of the patient. And if you do that, you will most likely be fine. Thank you.